want to talk to you today about the child with a musculoskeletal alteration. And by the end of this session, you should be able to discuss the pathophysiology and nursing care of the more common musculoskeletal alterations seen in children. Describe the various treatment modalities used in children with musculoskeletal alteration. Just to give a background to the development of the musculoskeletal system, newborns have more bones than adults. The cranial bones and other small bones in the coccyx or sacrum fuse during infancy and childhood, resulting in adults having 206 bones. Cardiogenesis at birth evolves and ossifies through osteogenesis. Primary ossification occurs in the diaphysis, the center of the bone. Secondary ossification occurs at the epiphysis, the end of the bone. Physis is a growth plate, is formed between the primary and the secondary ossification center and allows for longitudinal growth of long bones. It absorbs shocks, protects the joint surfaces from serious fractures. Metaphysis is above the growth plate and is composed of cartilage and is the area between the diaphysis and the epiphysis. There are 5 classifications of bones. There's the long bones, an example of which is the femur. There's the short bones, an example is the carpal bones in your hand. Irregular bones are the vertebrae. Flat bones would be the ribs, and sesamoid bones are the patella. Joints are composed of connective tissue and cartilage, connect 2 or more bones to one another and enable movement. Defective joints in children can be caused by neuromuscular disorders such as spina bifida and arthrogryposis. Alterations in joint movement may indicate trauma, infection, or arthritis. When we talk about the muscular system, it helps to stabilize joints. It's attached by tendons to bones. Muscle disease in children presents as muscle weakness, spasticity, myoclonus, and myalgia. Cartilage is dense connective tissue. Deficiencies in this may include Marfan syndrome and osteogenesis imperfecta. Musculoskeletal development helps to stabilize joints and maintain contact between articular surfaces. Muscles are attached by tendons to bones. Muscle disease in children present as muscle weakness, spasticity, myoclonus, and myalgia. This is a child here in a cast. This is a child in skeletal traction. And now I want to talk to you about neurovascular assessment. And that constitutes skin color, capillary refill time, temperature, sensation, movement of the digits, pulse distal to the site. This assessment constitutes your physical assessment of any musculoskeletal alteration that may come into the hospital or clinic. These are the things that you're going to do with every assessment related to a musculoskeletal problem. So when we talk about neurovascular assessment, we're talking about circulation, sensation, and motion. And signs of impairment would be coldness, pallor, blueness of extremity, swelling, loss of motion, numbness, and tingling of extremity. When we talk about paresthesia, numbness, burning, or tingling is a serious concern, and that can lead to paralysis if not corrected. Here are the 5 P's of ischemia: pain, pallor, pulselessness, paresthesia, and paralysis. Again, the 5 P's are so important in evaluating the musculoskeletal patient that you have. Pain or a burning sensation may indicate tissue ischemia. Prompt intervention is crucial and requires referral to the physician. Consequences of immobility: alterations in the various systems can be affected. Integumentary, impaired skin integrity. You want to assess for red or irritated skin, ulcer formation, or drainage. The children need to be repositioned every 2 hours or as needed. You want to make sure that the diapers are changed frequently so as not to reduce the risk of skin breakdown. Pay attention to skin breakdown of the heels. Use an egg crate type mattress or sheep wool blanket for extra comfort. Gastrointestinal risk for constipation. Why is that? Because of gastric immobility due to pain medicine and lack of maybe appetite, so they're not eating and drinking as much. So you're going to see decrease in number of consistency or bowel movements, decreased gastric mobility. You're going to assess the bowel sounds, abdominal distension, elimination pattern. Provide the diet high in fiber and increase fluid intake. Administer stool softeners. Most often they're going to be on narcotics, which is going to slow the bowels down. So administering a stool softener is going to be important. Respiratory, ineffective breathing pattern, decreased or altered respirations, shortness of breath, adventitious breath sounds. Assess respiratory status every shift. Encourage cough and deep breathing, blowing bubbles, incentive spirometer, blowing on a pinwheel, getting them to use the incentive spirometer 10 times every hour while awake and every 2 hours while asleep. Repositioning every 2 hours, making them deep breathe and cough, is going to help them loosen those secretions and mobilize them. Genitourinary, impaired urinary elimination. So it's going to be decreased urine output from stasis or retention. You may see some foul-smelling urine. Maintain hydration and monitor their urine output. Musculoskeletal, impaired physical mobility. Reduced strength and joint mobility, loss of muscle tone or atrophy. Encourage active range of motion, stretching exercises, and provide foods high in protein and calcium to improve tissue integrity. Having the child use the unaffected extremity is going to be important because they will tend to regress and want to not use their extremities at all, whether they're affected or not. So encouraging the use of using the hand that's not affected, or walking on the leg that is not in a cast, or moving it around with using exercises is going to help. And then finally, growth and development. So most children are going to feel powerlessness. They're going to have developmental regression, irritability, anxiety, dependency on others. You need to recognize the child's need to regress due to immobility. They've lost their autonomy. Provide therapeutic play and encourage them to participate in care as well as their families. And one last thing, the range of motion, whether it be weight-bearing or non-weight bearing, and decreased mobility. You want to always inspect the area for discoloration, swelling, palpate to touch for cool, warm, or clammy skin. Vital signs are going to be important. It's going to help you assess if they have an elevated heart rate or blood pressure. It may be because of pain level. If they have an increased respiratory rate or decreased O2 sats, you may be thinking that they may have pneumonia. So your vital signs are going to be quite important to keep on top of for management. And then finally, pain assessment. Every 4 hours or when administering pain medication, using the same assessment tool each time you're evaluating the child for pain. Talk about immobilizing devices, and those include splints, CATs, traction, and external fixation devices. When we talk about splints, we're talking about they're being used to stabilize and protect or rest an affected area. They help to increase range of motion and function. They help to decrease pain. They're safe, effective, and cost-saving alternative to casting. Casts provide support and maintain anatomic position for bone healing or aids in correction of a deformity. Made of synthetic materials such as fiberglass and non-fiberglass or plaster of Paris. Fiberglass sets within 30 minutes. Water resistant, more susceptible to skin breakdown and infection. Plaster casts are set within 10 to 15 minutes, but they're not fully dry for 24 to 48 hours. They're not water resistant and they will break down if it gets wet. When we talk about traction, we're talking about skin and skeletal. But first, traction in itself is the pull or force exerted on one part of the body. It can be applied to the skin or the bone, can be applied to the spine, pelvis, or long bones. Continuous traction is exerting a constant pull and is used for fractures and dislocations. Intermittent traction provides periodic pull or force and is used for contractures, low back pain, or muscle spasms. Always assume the traction is continuous unless physician states otherwise. Removal of traction that was intended to be continuous could be harmful. This could cause muscles to contract and fracture alignment could be disrupted. When we talk about skin traction, it's non-invasive and it's well tolerated. Most effective for children who weigh less than 15 kilograms or younger than 2 to 3 years. It can be applied to the pelvis, spine, or extremities. It's not appropriate if a child has a skin infection, open wound, or extensive tissue damage. If traction is not set up properly, neurovascular impairment may occur. Skeletal traction exerts greater force than skin traction and can be tolerated for longer periods of time. Helps maintain bony fragments and assists in proper healing. General anesthesia is necessary for placement and removal. Most serious complication with this traction is osteomyelitis, which we'll talk about in a few more slides. There are two types of skeletal traction. There's the halo, which stabilizes the fracture or displaced vertebrae in cervical and thoracic area. Then there's the 90-90 femoral traction, most commonly used traction for complicated fractures of the femur, most effective in children older than 6 years of age. And then finally we have the external fixation device, which is used in the treatment of complex fractures, lengthening bone, or correct angular deformities that involve bone and soft tissue. Pins and wires pass through the skin to anchor the bone. You need to observe for signs of inflammation and infection, and proper skin care is going to be important to reduce the risk of infection. Fractures is a result from increased mobility, inadequate or immature motor cognitive skills. There are two primary causes, either from trauma or non-accidental trauma. When we talk about trauma, it's usually because children are just learning to walk or their inadequate motor and cognitive skills that cause them to have falls or motor vehicle accidents. Non-accidental trauma refers to like child abuse. There are also other reasons for fractures, and those could be pathological in origin. In general, children's bones are less brittle because they have a higher collagen to bone ratio, so incomplete fractures are more likely. They have a stronger periosteum, so complete fractures are less likely. The epiphyseal plate or growth plate of the child is the weakest part of the growing bone and bears the brunt of bone injuries. Fractures in infants are usually the result of trauma during birth or non-accidental trauma, and this needs to be ruled out for child abuse. Clavicle fractures can occur at any age, commonly occurring with contact sports. Falls is a major cause of fractures. The distal forearm is the most common fracture, followed by the clavicle. When we talk about the pathophysiology of fractures, fractures are either simple or compound fractures. And we mean by simple fracture, it means closed, meaning the skin remains intact. So possible complications to this fracture: internal hemorrhage, compartment syndrome, or neurovascular compromise. When we talk about an open fracture, a compound fracture, we're talking about open, meaning the skin or the muscle has been disrupted. Physically, you can see it. The possible complications to this is infection, blood loss due to external hemorrhage. Some of the signs and symptoms that you will see is pain, tenderness at the site, immobility of decreased range of motion, deformity, swelling, crepitus, erythema, muscle spasm, and inability to bear weight. The treatment for fractures is one of two ways, and we'll get into that. Of the different types of fractures that kids can succumb to. They can be from the epiphyseal plate, they can be a dislocated joint, it can be a fractured radius or ulnar, supracondylar fracture. So when we talk about the treatment measures for fractures, we're talking about reduction, either closed or open reduction. That's how mainly fractures are treated. And reduction just means that the repositioning of the bone fragments into normal alignment. When we talk about closed reduction, that's the manual alignment of the fragments followed by immobilization. Open reduction, it's just basically surgery. So they're going in and doing a surgical incision of internal or external fixation devices using rods, wires, or pins to hold that bone together. And that hospitalization is required for this reduction. So closed reduction, not hospitalization. Hospitalization is not required. Open reduction, they're going to go in, do surgery, put pins or rods or whatever else they need to internally or externally fix the fracture, the broken bone. When we talk about retention, it's just the application of a device or mechanism that maintains alignment until healing occurs. Now, this all may be just what, treatment is necessary. And that would include, after the closed reduction, or open reduction, you may go to, once the bone is aligned using those two methods, the fracture site now needs to be protected so that it can fully heal. So then they would go to using a splint or cast or external fixation or traction to immobilize the area so that healing can fully occur. When we talk about soft tissue injuries, we're talking about sprains, strains, contusions, and dislocation, and we'll go through each of these definitions. Sprains result of trauma to a joint in which ligaments are stretched or are partially or completely torn. Strains, also known as pulls, tears, or ruptures resulting from excessive stretch of a muscle. Contusions occur when soft tissue, muscle, or subcutaneous tissues are damaged. Dislocation occurs when a joint is disrupted that articulating surfaces are no longer in contact. Some manifestations that you'll see: pain, swelling, localized tenderness, limited range of motion, and poor weight bearing. The treatment is to control the swelling and prevent further injury. Ice should be applied to the area to reduce swelling for no longer than 20 minutes at a time. Non-steroidal anti-inflammatories, or NSAIDs, to help alleviate pain and to reduce the inflammation. Elevating the extremity to level of the heart to promote venous return and reduce the swelling. The amount of time needed for healing is dependent on the severity of the injury. When we talk about the treatment of soft tissue injuries, we're talking about the acronyms RICE and ISIS. RICE is rest, ice, compression, elevation. ISIS is ice, compression, elevation, support. When we talk about osteomyelitis, we're talking about bacterial infection of the bone. It involves the cortex or marrow cavity. Considered chronic if the infection persists longer than a month or does not respond to the initial antibiotic protocol. The most common bacteria is Staph aureus. Group B streptococci in neonates, MRSA, Streptococcus pyogenes, H. influenza, and E. coli also are pathogens that can cause osteomyelitis. Salmonella seems to be the most common cause of osteomyelitis in sickle cell children. Typically, this affects preschoolers younger than 6 years of age, and boys are more often affected than girls. Clinical manifestations. It would be localized pain, swelling, warmth, tenderness, unusual odor, fever, irritability, or lethargy in young children. They have a limited range of motion, pain usually localized and can radiate to adjacent joint, septic arthritis. The diagnostic means is an elevated CRP, which is reactive protein, C-reactive protein, elevated eosinophilic sedimentation rate, elevated white blood cells. Blood culture is going to be positive, and you're going to get high-dose IV antibiotics, parental IV antibiotics. Organisms involved dictates the choice of antibiotic and length of treatment. Osteomyelitis is very difficult to treat. Oftentimes, these children will go home with PICC lines, which is a long-term IV access, so that they can have antibiotic therapy at home for longer than 10 days because it's so difficult to treat because it's in the bone. When we talk about compartment syndrome, this results from swelling caused by trauma or immobilizing device. Swelling causes pressure within these closed fascia compartments to rise, compromising vascular perfusion to the muscles and nerves. This is a true surgical emergency to prevent paralysis and necrosis of the tissue. Some signs and symptoms that you will see: severe pain unrelieved by analgesics, neurovascular impairment. If extending fingers or wriggling of toes produces pain, poor or absent pulses. Any of these signs and symptoms, you need to notify the physician immediately. Late findings of compartment syndrome is paresis and parathesis. Paresis is weakness. Parathesis is numbness, burning, and tingling. Excuse me for not being able to pronounce that correctly. And these are late findings and a sign of permanent damage. When this occurs, when you suspect compartment syndrome, immediately elevate the extremity only to the level of the heart. Loosen restrictive bandages or dressings. Split the cast if possible, and notify the physician immediately. Give pain medicine as needed. Musculoskeletal developmental disorders. We'll go through each of these: scoliosis, hip dysplasia, leg calf Perthes disease, slip capital femoral epithesis, and clubfoot. When we talk about spinal cord or spinal column defects, we're talking about lordosis, kyphosis, and scoliosis. Scoliosis being the most common, that's what I'll emphasize here today. Lordosis is the exaggerated concave curvature of the spine, usually in the lumbar region. Kyphosis is the natural curvature of the thoracic spine. Normal range is between 20 to 45 degrees. Hyperkyphosis is an angle above 45 degrees. Postural kyphosis is benign and can be corrected with proper posture techniques. So now we're going to be discussing scoliosis, and this is the lateral deviation or curvature of the spine. Curvature greater than 10 degrees. If worsens, rotational structural deformities are seen in the vertebrae and rib cage and can compromise respiratory function. This can be classified as congenital because it can occur during fetal development. It can be caused by a syndrome, such as Marfan syndrome. It can be neuromuscular, usually involving the whole spine. It can be caused by spinal tumors or neural axis abnormalities like a tethered cord. Or it can be caused by thoracogenic, caused by a thoracotomy approach for surgical repair of unrelated condition. So adolescent idiopathic scoliosis is the most common type of scoliosis. Females have more progressive curves than males, and the curvature has to be at least 10 degrees in order to be considered scoliosis. So manifestations that you'll see: visible curvature of the spine, a rib hump when the child is bending forward, asymmetrical rib cage, uneven shoulder or pelvic heights. You'll see prominence of the scapula or hip and leg length discrepancy. Complaints of back pain are considered atypical. This is why in school, boys and girls are screened on a regular basis for this. Girls can be screened at 10 and 12 years of age. Boys screened at either 13 or 14 years of age. Adams Forward Bend Test and Scoliometer is a small level device to provide angle of vertebral rotation. When is it important to refer to orthopedic surgeon? If the scoliometer readings of 7 or greater indicates a 7-degree angle or trunk rotation. Radiographs are used to determine the curvature, and the Cobb angle measures this curvature on the radiographs in both the carinal and sagittal views. When we talk about non-surgical treatment, curves less than 25 degrees require observation of progression. Patients closer to 25 degrees, skeletally immature, will require more frequent radiographic observation than a patient with a smaller curvature who is skeletally mature, meaning who has reached puberty. Progression is defined as 7 to 10 degrees increase in the Cobb angle. Remember, the Cobb angle is a measurement obtained for all curvatures on radiographs in both the carinal and sagittal views. Brace treatment is recommended who present or progress in curve magnitude at 25 degrees or more and are still skeletally immature. Goal is to prevent further progression. Lumbar curves wear a nighttime only brace. Other curve patterns require 22 to 23 hours a day of bracing. So you want to wear a form-fitting t-shirt and underneath the brace to reduce the skin breakdown and irritation. For girls, brace wear is discontinued after the patient is 1.5 to 2 years post-menarche, meaning 1.5 to 2 years out from after starting her period. The riser grade suggests near skeletal maturity and no further increase in height. The riser sign grades 1 through 5 and determines the probability of whether or not the curve will progress. So for girls, 1.5 to 2 years after starting their period, the brace is generally discontinued. And the riser grade will suggest near skeletal maturity and no further increase in height. So it grades 1 to 5, and this will determine the probability of whether or not the curve will progress. Sometimes surgical intervention is necessary, and that's necessary for curves that reach 40 to 50 degrees. The goal is to reduce the size of the curves and obtain fusion of the treated part of the spine. Significant blood loss is common. Potential complication of surgical correction can be an insult to the spinal cord. Risk of infection, implant failure, progression of deformity, and post-op management. The main area here is pain control with a PCA, pain management is going to be crucial to correction of scoliosis with a spinal fusion. I've seen this time and time again, that children with spinal fusions are in severe pain after the surgery. So pain management is going to be essential here, as well as mobility, discoloration, palpation of the extremities, skin is warm or cool to the touch, capillary refill. When we talk about developmental dysplasia of the hip, the exact cause is unknown, but genetics may play a role. Risk factors are the firstborn child being female, breech position, and low levels of amniotic fluid. Some manifestations as symptoms may vary according to the age. In neonates, instability of the hips, femoral head can be displaced partially or fully from the acetabulum. Infants show an asymmetry of the gluteal skin folds when lying with the legs extended against the exam table. Affected hip has limited range of motion, and asymmetrical abduction is present. This is often diagnosed on ultrasound, and it's more sensitive than using a radiograph. The treatment depends on the age of the child. You want to facilitate normal development of the hip socket. Oftentimes, these children are put on a Pavlik harness for newborns and infants younger than 6 months of age. It helps to maintain hips inflection, abduction, and external rotation. It consists of shoulder and chest straps and foot stirrups. Initially, the harness is worn continuously. This may be the only treatment necessary to correct this problem. Improper positioning of the hips can cause interruption of the blood supply to the head of the femur, resulting in avascular necrosis, tissue damage caused by inadequate blood supply. After the newborn period, closed or open hip reduction surgery, immobilization for 3 months, and a spica class follow the procedure. Leg calf Perthes disease. It's an avascular event affecting the epiphysis of the femur and prevents further growth of the ossific nucleus. This results in an increased bone density. The cause is unknown. It's considered a growth disorder, and children are usually shorter than average height and many were low birth weight as infants. It occurs in 15 of every 100,000 children, boys to girls 5 to 1. And it's commonly seen in children between ages 4 and 10. The most common symptom is persistent pain of the hip that worsens with movement. Pain may be intermittent over a period of weeks or months, can be felt in the groin, thigh, and knee, may have limp or limited range of motion. Most serious complication with this is permanent deformity. Radiographs of the femoral head is diagnostic. Overall, the treatment goal is to prevent deformity of the hip and delay the onset of arthritis and degenerative joint disease. Initial treatment is with anti-inflammatory medications, range of motion exercises, and bed rest. Surgical treatment of an osteotomy, which places the femur more securely into the acetabulum. When we talk about a slip capitofemoral epiphysis, it occurs during a rapid growth in adolescence. It's the shearing force causing the femoral capital epiphysis to displace from its normal position relative to the femoral neck. The cause is unknown. Most frequently occurs in adolescent boys who are overweight. Some manifestations you will see is a limp and pain. The pain is in the groin, thigh, or knee, intermittent and worsens with activity. Epiphyseal plate begins to thin in response to hormonal changes during adolescence. Increased weight and height causes more stress in the epiphysis, causing relative displacement of the femoral neck from the femoral head. So the treatment here is hospitalization and internal fixation of screw or pin inserted across the growth plate, securing the femoral head and preventing further slippage. You need to use crutches for 4 to 6 weeks and non-weight bearing. When we talk about the club foot, it's a congenital dysplasia of all tissue below the knee. The incidence is 1 in 1,000 live births, and both feet are affected in nearly 50% of patients. Heredity and race and not environment play a factor in occurrence of club foot. It's more common in males 2 to 1. Clinical manifestations of club foot is recognized on clinical examination. It can be diagnosed prenatally on ultrasound. The treatment goal is to reduce or eliminate all of the components of the deformity so the child has a functional, structural, mobile, pain-free foot. Oftentimes, these children are put in the Ponseti casting method. It's the standard of care for clubfoot treatment. It requires weekly, gentle stretching and manipulation of the misaligned bones, followed by application of a Wee-molded long leg plaster cast. Correction of the deformity is obtained within 6 to 8 weeks of casting, with a percutaneous tendon Achilles lengthening is frequently performed before the final cast application. Application of a topical anesthetic cream during tendo Achilles lengthening would be most helpful. The final cast is applied for 3 weeks. After the casting is done, the foot will appear overcorrected. To maintain the correction, abduction orthosis is used full-time for 3 months, followed by 12-hour nightly use until age 2 years of age to prevent reoccurrence of deformity. Here's an example of lordosis here in the lumbar region of the spine. This is scoliosis, so it can occur anywhere along the spinal column. Again, greater than 10 degrees to be considered scoliosis. Kyphosis is the curvature of the thoracic region of the spine. This is a picture of a child with gena varum, bow legs, space between the knees. This is a normal finding in a toddler who's just beginning to walk. Gena valgum is knock knees. There is a space between the ankles and the knees when they come together. This is a normal occurrence up until the age of 8. Beyond 8 years of age, it needs to be surgically corrected. This is a picture of the club foot. And again, 50% of cases you will see bilateral feet affected. The child with muscular dystrophy. The nursing outcomes for this child is to maintain physical activity, promote respiratory function, manage the weight, and reduce the impact of the disease on the child's development. When we talk about muscular dystrophies, it includes more than 30 genetic diseases, progressively degenerative, inherited diseases that affect the muscle cells of specific muscle groups, causing weakness and atrophy. Duchenne muscular dystrophy is the most common occurring in 1 in 3,500 male children, accounts for 50% of all muscular dystrophy. It's progressive, symmetric muscle wasting and weakness without loss of sensation, first appearing after walking is achieved. Waddling, wide base gait. Calf muscles are weak and hypertrophied. Muscles of the pelvis and the shoulders are affected. Walking ability is lost by age 9 to 12 years of age. They have a shortened lifespan, and they often will have other comorbidities such as cardiomyopathy, cognitive disability, and moderate obesity. The diagnosis is made with a serum CK level and are often elevated in the early stages, along with a muscle biopsy. The treatment is aiming at maintaining ambulation and independence for as long as possible. Activities that promote range of motion and mobility, such as swimming, is often helpful. Kristen Age 10, sustained a fracture in the epiphyseal plate of her right fibula when she fell out of a tree. When discussing this injury with her parents, what should the nurse consider? A. Healing is usually delayed in this type of fracture. B. Bone growth can be affected by this type of fracture. C. This is an unusual fracture site in young children. D. This type of fracture is inconsistent with a fall. The answer is B. Bone growth can be affected by this type of fracture.